So now let me officially introduce Dr. Hilty. He is a scholar in psychiatric and medical education, health services, and telemedicine. He works as a professor of psychiatry at UC Davis School of Medicine with the United Health Services in Heritage Oaks Hospital to develop, he works as a professor, got that, hospital to develop virtual care and has assisted the Veterans Health Administration to implement technology. He speaks internationally and researches models of care, health service design, health economic outcomes, and implementation of video, mobile health, sensors, and other technologies. And I'm also privileged to call him a friend. So Dr. Hilty, if you can take it away, I'll exit stage left.
Thank you, Dr. Felker, and thanks to the entire team who made this possible and the invitation. It's great to see everyone today. You're in the home stretch here. It sounds like it's been a great conference, and I thank all the people who have helped with my career at UC Davis, USC, NorCal, VA, and currently UHS, and across all the different professions and teams. It's been a pleasure. The goal for this presentation is to consider how we prepare the current and future workforce for telebehavioral health. And in order to do that, we need to look at the clinical and administrative landscape for learner skills and attitudes. It's not just about quality of care and research. How do we really prepare people for workflow? We will look at how to use synchronous video and asynchronous technologies as an example of clinician and institutional competencies, and highlight professional development and technology fatigue issues. Disclosures have been mentioned above, but these are a few of the organizations I'm working with across the world. It's been a real pleasure. What's our context for learning? Well, we've gone from Web 1 to Web 5. We're just finishing the pandemic, so to speak. Healthcare in the last year or two has focused on the quadruple aim: patient-centered, team-based, metric-driven, and population health objectives. Each of us is looking at our virtual life and work on a range from isolation versus connectedness, and this is the same for patients. And we're getting feedback on well-being and resilience for both patients and clinicians. It's very important. Professional development, ideally, is with passion and purpose rather than rote or procedural, but we'll consider that theme today, and we'll look at principles, methods, and outcomes related to that. If your experience is like mine over the last few years, it's been a little bit not like a roller coaster, but truly a corkscrew. We've gone through a lot of change, and yet I think we're in a better place, and I'll try to share some of that and the vision for the future. The landscape for telepsychiatry, I started in 1996 at UC Davis. But around 2000, we were trying to figure out, is video good enough? Does it simulate in person? Is it really like being there? Are patients satisfied? Is it feasible? And back then we had low technology and we had some disconnections and also some quality problems. By 2005, we realized that it seemed reliable and valid. The outcomes appeared to be as good as in person, at least on preliminary studies. And we began shifting from only video to considering other e-health options like text, email, and disease management. Around 2010, actually in 2008, the ATA guideline came out for video care. And that few years, we were also looking at how to leverage expertise in systems, getting a psychiatrist to rural areas, or what parts of the treatment team are needed in an urban area that we don't have, and might video help us with that. By 2015, we were looking at how to do collaborative care. Some of this was video and web-based interventions, and some of us were looking at integrated and stepped care by video, though very few programs have done that. And we looked at how to combine these synchronous and asynchronous technologies. This particular 5-year span, we're seeing much more interest in population level impact and effectiveness, and some of us study economic impact and cost analysis. A lot of this goes back to implementation science and translational research in this pandemic and post-pandemic era. Implementation science, most of you are familiar with, or some of you are experts on this, but the core components are acceptability, adoption, appropriateness, feasibility, fidelity, cost, penetration, and sustainability. These are the principles that allow us to be creative and start services, but evaluate them properly and then sustain them with the goal of quality of care and long-term impact, preferably individual patients in a population. In the VA system, I got more familiar with process improvement strategies, including lean, and this really helped us consolidate our mission across all levels of staff, clinicians, and administration, and most importantly, working with patients and families to identify what did they value rather than us assuming what they value, and how do we map the value over time and through clinics and across services. And those of you who have participated in this, you know it's a very interactive, dynamic process where you identify barriers, you say exactly what's on your mind, and we look at all users in the system. And we seek perfection, but lean is really about not shooting for ideal states, but a reasonable good state. It embodies the philosophy that we try to do our best care. We also, in the VA, and the university systems have used team-based care principles. And many people in mental health assume because we come from different disciplines that we're doing team-based care. However, team-based care itself is very purposeful with coordination, communication, and teamwork. It's a theory based on a shared mental model of expectation, roles, and outcomes. And to the degree we talk about that and make it explicit, the more we're on the same page and stay on the same page with the patient and their family as our key objectives. How do we help them? So we share ideas, we plan, we support one another, and we deal with crises. And some of these are formal meetings, and then other as important options are brief huddles. And some of these are featured best in primary care beyond behavioral health. The telecollaborative care, stepped and integrated care movement has embodied this, and it really emphasizes how important interprofessional care is across teams and disciplines and systems. This is how I like to, visualize team-based care. And the nice thing about the pandemic, one of the positives is that we have really worked together across country barriers and boundaries, and we've helped each other develop best practices, and we shared ideas, and some of this was on the team, but a lot of this was across the world, and that's why the work with other organizations is so important for us in the United States and elsewhere. It says I'm a gladiator, but that's just what I do to put food on the table. What I really want to do is teach. So this is a dedicated slide to all you teachers and people who help with education for all levels of your organization, from trainees to staff to all of us, because we need to continue learning. The student and resident interest in telepsychiatry, mainly video, has been assessed in a few studies, and many trainees were waiting for experience in the faculty who have skills to show them. Pre-pandemic, there was a need for curricula for adult and child and adolescent trainees or residents and fellows, and they identified professionalism in using technology as a high priority. This survey, pre-pandemic, at USC and a couple other institutions, showed that a lot of trainees were not getting much experience. But the interesting thing about this study is that while a few hours of video experience with patients was helpful, there was a somewhat interesting pattern that to build skills, you needed 6 to 20 hours of experience. And the experience also allayed concerns about dealing with technology, and it increased interest. Sharing resources across institutions was at that time helpful because a lot of people didn't have experience, or faculty who had experience with technology. Technology competencies were nonetheless being put forward. A lot of them were with our group, and these are people across the United States, Canada, and many other countries. Video in 2015 and 18, and then an international behavioral health organization, Coalition for Technology and Behavioral Science, came out with additional domains, legal and regulatory, telepresence and telepractice. Some of us worked on social media competencies, and Dr. Zalpuri had the lead on that. And then we also began, as you can see, to look at video and culture, or mobile health and culture. How do we look at technology literacy, but also cultural literacy and healthcare literacy in making technology user-friendly for all people involved? Eventually, we got to asynchronous competencies, and some of those include wearable sensors. So the competencies are focused on skills and attitude more so than knowledge. And we thought with technology, skill was the key in providing good patient care. The competency frameworks can be compared. CAN-MEDS is a fabulous system of competencies, and you'll hear more about that in a moment. And the Canadians have done quite a bit with competencies in professional development in general, really a leading place in the world. The AAMC put out some telehealth competencies for students. They were quite basic, but you can see they were in helpful topics like safety and data collection and communication, among other things. Our original competencies followed the six domains that were used for graduate medical education in the United States, and you'll hear more about that. And then the CTIBS competencies added a few other domains here you can see, as I mentioned earlier. So there are many good frameworks, but the goal is to develop skills and attitude. So if you look at graduate medical education in the US on the left, and CAN-MEDS, a similar system on the right, you can see these domains seem a little bit different from CAN-MEDS. CAN-MEDS framed theirs in roles rather than domains per se. And I think roles are very helpful for people to organize their day and their approach to patient care and problem solving. But both systems are very good. We have to be concerned with learning levels. Of course, this is for all of our staff and patients too. And we develop these skill sets based on pre-competency, meaning a novice or advanced beginner. Now, some of these would be medical students and early residents, although there are also faculty who were novice and just beginning to use technology. Core competencies would be with a clinician, often who's a late resident or an early faculty, who's teaching and understands how clinical care and technology really goes together. And then advanced competencies are the trainers per se. And this parallels the American Association of Medical Colleges framework on pre-entrustable and entrustable professional activities, the transition from medical student to resident. Now, the paradox in all of this, as many of you know, is that some students and residents are technophiles, meaning they're very specialized in technology. And that can help us as faculty. On the other hand, it can be a liability, because if they assume that their personal use of technology is similar or the same as professional use of technology, they are often surprised. For example, there are things that they would post on their social media or in text that become common behavior and habit, but when it comes to patient care, certainly we can't do those things. So we have to have policies and procedures that embrace our professionalism. If you wanted to look at what a sample competency might be, some of those papers and the references will have more specifics, but you start with history taking, and a novice beginner is often just learning in healthcare what is a standard history. And they may be able to think, how can technology help with this? Or what parts of the history do I need to ask something specific about technology? For example, you might ask a patient, have you seen a doctor by video? How did it go? What was it like? Did it work okay? And whereas a competent proficient provider anticipates issues employs team members more fluently, and just has a way of conducting interviews such that the users, mainly patients, don't even know the technology that is there. Or they help people feel at ease by making a joke or just talking about how technology works in life before they start. It's very key with technology to engage people, build trust and rapport. And some of that happens automatically with our work, but sometimes we have to adjust our interview. We can't give someone a handshake, as we often did pre-pandemic, and we have to prevent distractions and interruptions. We have to have our cell phones off, or we have to have examples of when we will pause an interview predetermined and have that prepared. In terms of assessment and physical examination, novice and advanced beginners are often learning the tools. So for a cognitive exam in psychiatry, the mini mental status examination is something they're learning to do. But a competent, proficient person knows that there may be 2 or 3 items in an MMSE you can't do over the video, and you make a substitute that's reasonable and somewhat evidence-based. And then finally, with treatment planning and management, it depends on the model of care. You might outline a treatment plan. If I'm going to do the treatment, I would go through the biopsychosocio and cultural issues, or I would outline the plan if they're following up with a primary care provider or PCP. And it's important to clarify that and decide who's doing what. In a collaborative care model, you would have a psychiatrist and a PCP doing care together on alternate visits, sometimes together. But let's look at the big picture of curriculum for our learners. In order to know how to help learners, we have to assess what their needs are. We can't assume them. And then if we do that, we can set objectives. And then we develop strategies to help them achieve those. We implement and evaluate. And then we identify problems if there are barriers. So it seems easy when you look at this flow chart here, but to make that happen in a clinical setting is challenging. So we look at learning levels, we look at learning styles. So some of us learn visually or in person, some do quite well by video. Some attention to experiential learning is important. So what I was saying earlier is that for people in that one study, having a few sessions to experience the technology and feel what it's like is helpful to get the landscape, but then you have to develop the skills, and that takes a little bit more time. Some faculty are very natural teaching by video or supervising by video. Others don't like it at all, and it's important for us to try new things, and while we're doing those, to have an open mind so that it role models positive expectations for the others on the team. Stakeholder input is always important, and that's why we do the needs assessment and the 360 evaluation. And then hopefully we can consensus on what methods we use, and Delphi and other processes are helpful for that. So some of this is a review for you, but if not, you can pick one thing or two and read up on it. So the punchline is, how do we meld the skills into the practice, into the clinical workflow? Well, it takes preparation. You're probably ascertaining, if you didn't already know that, this is not the just do it model, as a popular American business company often says. We prepare, we focus on basic skills, we look at clinical factors, technological factors, and administrative factors, try and create a culture and a space where people share the most important things in their life, and that includes patients to us, or teachers and learners letting their guard down and sharing and teaching and learning together. We have to self-reflect and improve. There's no shortcut for that. What did I learn today? After this presentation, for example, what went well today? What didn't? What might I change for the next time? And we build new skills, and we become better at that when we teach and train others. So some do's to keep in mind. Try to assess in advance, where does a skill or technology fit in the practice? What could it be good for? What would it not work for? And then try it out. What are the individual needs for the patient or for myself. What do my team needs? What works and what doesn't? Most important, do practice and trial runs. That gains experience and perspective as well as some skill. Don't be afraid to look at errors. Errors can help us. We should be open-minded about that. And in education, this is a fundamental tenet. Help others in time if they're struggling. Also have assistance from a technology point of view, someone you can call if there's a problem you haven't seen before. Collect information along the way, have a backup plan or three. For example, back in the early days, the video went down completely. We hopped on the telephone, we finished the interview unless there was a problem with that. At a system level, it's very important we create an authentic, interactive environment. This has to be as close to in-person as possible. On some occasions, it's better than in person. There are some patient populations, trainees and clinicians who are just natural at technology. They find things that they can do in technology that they didn't do in person. It might surprise you to say that because in person is the gold standard, but we have to be open to our strengths and weaknesses individually and in groups, and technology has been really good for some patients. In fact, they find it easier to talk in technology and they're more forthcoming than they would be in person. So we learn from our mistakes, we role model, we guide and help with best practices and policies, and we learn with patients and trainees all together. We're all in this together. Now, one shift, this may be somewhat new to you, is the idea of institutional competencies. So in an academic institution, for example, you think about the patients, you think about trainees, faculty, staff, other professions on the team, and then you think about the clinic or hospital administration and the academic health center. That includes schools of medicine or nursing. It may include hospitals and health systems. But we can't just throw technology into the workflow without assessing readiness and sort of creating or hardwiring a culture that works. So one of our foibles from years ago is when the information system people decided to implement electronic health records, and they did an initial training and then they turned us loose, and we struggled because we hadn't done that before. And what we realized is that we needed policies and procedures to guide us, and we needed retraining periodically to make sure we were doing the right things and correct the things we weren't doing. And some of this has to be explicit, and that's why I talked about curricula and competencies. It's not a knowledge thing. We can't expect the average healthcare provider or patient just to do something based on knowledge. We have to have experience, comfort, and develop the skills. And so training is key for all of us. And then we have to evaluate and manage change. So some of this is spelled out in the articles listed. Another thing is that some of you have done quite a bit of video or mobile health care. And the good news is it's working, patients like it, it's helpful, it supplements in-person care. Some patients may be using both in-person and video alternatively. But it's important that we evaluate our video and mobile health services with standard measures. So I put in some of the standard measures here for healthcare, whether it's the Agency for Healthcare Research and Quality or regulatory bodies. And the Joint Commission doesn't do too much in this area, but the National Committee for Quality Assurance and CMMS have really come up with some adjustments that we need to do. Some of them are documentation and billing, of course, but that's just the way it goes. And then we have to evaluate healthcare in terms of economic outcomes. And healthcare is a little bit late to this particular endeavor. So we really need standard cost studies for all healthcare interventions, and more than what did it cost or did it provide some value. We need to look at good measures for efficiency cost effectiveness or cost benefits, then that's a different level. And Dr. Serhal and from University of Toronto and I have published a paper in telemedicine and e-health if you want to look at that. Another thing you might have to consider related to your technology service is a professional development program. So you have your standard professional development within your training and education or departments or in your organization, but you might have to adapt that a little bit to technology. And the best way to do that is to assess, well, what's different in the workflow and how do we adjust to that? For example, if we add video to care and it requires me to do 2 or 3 extra things, how do we make that happen? And how do we make sure that we do them in the correct way and that they don't affect engagement? And so when we're talking about professional development in the decades ago, we went to courses and we attended lectures, but workplace professional development in this era is about topics, group projects, and peer support, not cross-sectional, but longitudinal. And we want to think about things that will help us across teams and professions. That way we can support each other, because we don't just work as individuals, we work as teams. And this requires supervision, peer mentoring, some coaching, and even some individual mentoring. So if you haven't thought about professional development, aside from just getting trained on technology, now may be a good time to make that more explicit. An important issue that has surfaced over the last few years, particularly with the pandemic, and the good news with the pandemic that all of you probably already know is that we gained a tremendous amount of experience with technology, and we couldn't help but develop skills, and now we can build on that momentum and really get specific with professional development and training and make sure we have those skills. However, because of the workflow issues with in-person care and technology, we realized that patients and providers have experienced some fatigue. Part of this was the initial adjustment to the pandemic, completely unrelated to technology. Some of it was disruption of personal and professional life that we all experienced. However, as we were building intensive technology-based services, many reported feeling a little bit more tired, or they felt differently with patients, and we began to look at this in depth. So we did a search of the studies from 2000 forward, and that's 2020, and we looked at online video and mobile health technologies, and we were trying to figure out what is technology-based fatigue and what are its consequences. At the same time, we were trying to be fair to technology, not blame all the changes in workflow on it. So it requires ability to step back and think about what's technology and what's not. And some of this is published in the Journal of Medical Internet Research, and the next one is in the Clinical Social Work Journal. So what are the dimensions of digital fatigue? Well, there are human factors. Fatigue, fatigue, physical discomfort, sitting in a chair all day. And for example, is the chair that I use for video customized to my body, or did I borrow it because I went to a telehealth suite and it doesn't fit me at all? And then if you think about stress and burnout, and some of this has to do with digital literacy. I mean, do I know much about technology, or did I assume I knew a lot, but I really don't know that much? Some of the fatigue had to do with relationship factors. You know, what effect did technology have on the therapeutic alliance? Did my ability to be compassionate change by using technology? Did I miss seeing people in person? Did I feel isolated? There are also technology factors, and I mentioned some of those, environment or ergonomics, and depending on the type of technology you're using. And then there are system factors. Did my department chair ask me just to jump over to technology, but not quite give me enough staff support or technology staff support? How did we advocate for developing better workflows? Did I have two screens so that I could see the patient well and do EHR work on the other? Things like this really make a difference. We began to realize that there might be a spectrum from health and resilience to a place of risk of digital fatigue, and then manifestations of burnout in general or related to technology. So I won't go over all of this, of course, but if my clinical care with technology aligned with some of my goals and the care was experienced as therapeutic, I felt compassionate. It was very rewarding. On the other hand, if technology was seen as sort of peripheral and I thought it's not very good, or I was distracted and I didn't enjoy it, then I might be at risk not only for a bad attitude, but for getting tired as well. And then the burnout manifestations are on the right column here. Things get rote or get done. I might be impatient, inflexible, or angry, and I don't find it rewarding at all. And so if you look at this over, later in the day, if you have a copy of this, just think about where are you in terms of using technology? And I encourage you to look at where are you personally using technology versus where you are professionally. It may be different, it may be the same. So finishing up, what I tried to cover is the learning context and how important education, health services, and workflow in the workplace are. There's a lot more to doing telebehavioral health than showing up. And the same for developing skills than doing some kind of a module and gaining knowledge. There's a culture of learning and improving, and I really emphasize lean and implementation science, training paradigms, and research. And clinical competencies and professional development require institutional support and approaches. So I appreciate your time and attention, and we will have time for questions.
Well, thank you, Dr. Hilty. That was, as always, just fantastic. I can't think of a better way to end the two-day summit than with what you just shared with us in terms of how can we take real concrete steps to lay down a foundation on which to build our own learning to provide quality care, but to provide quality education and training for those coming next, who's going to carry the freight for us going forward. So to take such a complex amount of material and bring it down and provide us with such practical information, that was just fantastic. Thank you. But we do have some questions. So let's get to the questions. I'm going to refresh my screen so that I have the latest of the questions. Okay, first one is, would there be a recommended telehealth mental health provider training for student interns new in the field?
And did you say student internists?
Student interns new in the field.
Interns. That's a very good question. I don't think there is a simple answer to that. I think, first of all, you would want to check with your organization, whether it's a university or a healthcare system, and see if they offer any trainings. If they do, that would be a good starting place. There are regular continuing education programs at the American Telemedicine Association, with the Coalition for Technology and Behavioral Sciences. There are, the VA system has its own set of modules for that. And I think the most important thing is to, if you can find one based on skills and not knowledge acquisition, that would be important. And then as I said earlier, it's important to have some experience and either sit in on some sessions with permission and appropriate privacy things attended to, and then to actually do some sessions. That will be informative as much as going to a seminar. It's interesting, healthcare, at least in medicine, has really embraced technology beautifully. At the same time, a lot of the national organizations haven't come up with standardized training or modules because they didn't want to burden people with having to do specific trainings. They wanted to give them free choice. And I think one of the downsides to that is that we don't have things that are ready to go and best practices. So I think there's still room for development in that. But Dr. Felk, you might know of some yourself, and I would be open to hearing about that too.
Well, thanks, Ian. I'll be talking about our special edition coming up here in a moment, but interestingly, with this, we've been doing a telehealth behavioral health series, which I'll reference in a moment. And as you know from the commentary we published in JTIBS, that multiple universities have picked up this telebehavioral health series and made it core curriculum for their students and fellows. Got another question here. Which sort of relates to what we just said. Will schools, college, universities courses reflect the future of telehealth?
I think so. The pandemic did more in a few years than some of our advocacy work over 2 decades. And the good news is that our trainees, most of them were already embracing technology, and this just helped us. And once we can help them acquire the skills they needed, and they teach us, we all come out better. The other good news is that our patients have embraced technology, and they see it as a staple of care at this point. And most of that is easy for us to adjust to. It makes our life easier. I think there's one area that remains a challenge for healthcare and medicine, and that is that some people in healthcare don't see how social media really applies to healthcare. But I can assure you that the young patients and families have already decided that social media is part of healthcare. And so we have to embrace it, and we have to also ask them what they're doing with it, particularly in behavioral health conditions, because it has major impact. And any of you who have teenagers or kids know how important some of those issues are with stress and how much time they spend online and the other consequences of that. I think that also our medical students, residents, and trainees in other fields have also written dozens of important editorials and commentaries over the last few years saying, hey, we really like learning with technology. We want more of our seminars. We want more things with people, not just at our home site, but at other sites, because we can learn better with them. And let's make technology more of a central part of education. So I think that is really snowballing nicely.
Would agree. Next question. Have training competencies and/or curricula been examined with a lens on cultural competence within the telebehavioral health setting?
We're at the very beginning of this process. We put out a competency set for video and cultural issues in 2019. I referred to that. And it was a very good rudimentary set. And the good news is that many people started looking at cultural, technological, and health literacy. However, I don't believe we've done enough in this area. I have to say, one of the pieces of work that I appreciate all the collaboration from across Canada, Europe, and the United States on is the mobile health and cultural competency set we put out in 2021, and that's in the Journal of Technology and Behavioral Sciences. That paper looks at mobile health competencies versus in-person competencies in general. And it also adapts within it some cultural issues to use mobile health. It also, for the first time that we could see, outlined cultural competencies in a stratified way from early beginner or novice to competent clinician to advanced clinician. And this was just in culture. And this was based on many of the cultural studies and guidelines from the American Psychiatric Association and other national bodies. And so we looked at mobile health and applied culture. We looked at culture then in a way that was more explicit than the American college and graduate medical education system. And we put them together and contrasted them and integrated them. So that 2021 paper with Hilty and Crawford would be worth taking a look at because it will get concrete for you.
Next question. How will your telehealth services keep up with changing technology?
Well, I think there are a few keys to this. One is user-centered design. And it's important to find out what your patients and their families wanted to use, and then to expose them to technologies, sometimes in a studio, and just find out what works and doesn't. Especially the kids and adolescents will tell you what they like and what's not going to work. And parents find that helpful in those family studies as well. So user-centered design is key. I also think we're at a point in VA systems and large other enterprises where we can go to patients and say, you have options. You can do video care, you can do in-person care, you could do a few things by mobile health if we've got it ferreted out, or you can do combinations and see what they want to do and then sort of follow their experience, adjust it, and go from there. Many people assume that geriatric patients, those over 55 or veterans, wouldn't be interested in technology, and that's just not true. They embrace technology quite well. And I think the veterans, for example, find it empowering because they can receive their care at more than one place. And they can either go to another VA setting and receive it there, or sometimes they can receive it mobilely. So I think we're building technology into the fabric. So let me give one other slight analogy to this. From going back and getting an MBA, I had to learn about the basics of business. And there's research and design, there's financing, operations, and other things. The good businesses took technology and they integrated it with these paradigms of good businesses, where in the past, they did their business and they sort of slapped it on at the end and said, hey, technology, it's nice, we'll use it. But if you integrate it in your systems, you will do much more. Thank you.
Yeah. What are some things we can implement to allow the video/audio connections for patients and patient satisfaction with telemedicine to get better?
Well, I think in terms of our psychotherapies, it's important to have boards that people can draw and communicate and make it interactive, especially with some of our therapies for trauma. This is good, especially for kids and adolescents, it's good. And that can be theoretically part of the medical record too. I also think that we need to make sure that any texting that's going on and other mobile health technologies are fed into the electronic health record so that we can look at them. So, really wearable sensors. I mean, this is a microphone that I use for my cell phone, but we have wearable sensors that can go with me anywhere in my entire day. And what we're learning to do is to geographically watch where I go and then I can be prompted to assess my mood in the morning versus in the afternoon or the evening. And I can also log who I met or what kind of experiences I had. That data goes into a system, and it can help a clinician look at patterns, but it can also be fed back to me and say, you know, Don, your mood is better when you're doing A, B, and C. And that empowers me. So wearable sensors, and for the kids, ones that don't get soaked and ruined when you jump in a pool because you're being a kid, is really important.
Excellent. What are some digital tools organizations have used that have worked well for their system, especially for providers to use as adjunct to care?
Yeah, that answer is somewhat similar to what I just mentioned in terms of wearable sensors, but the having an electronic portal for organizing care, I think wearable sensors, so we're doing 24/7 rather than cross-sectional visits, allowing patients choices. Let's assume that I have an appointment with Dr. Felker today, and it was at 2 o'clock, and I got an email at 1:30 said, would you like to meet with Dr. Felker today in person? Would you like to meet with him by video, or would you like to do it by phone? Or what would you like a different method? Wow, how great would that be? I feel empowered, and that choice is really affirmative. So some of these are about technology, and some of these are just us getting healthcare out of the traditional clinic visit. It's so standard, or was so standard for a while. If we maintain quality, we evaluate it, and we make sure privacy and safety is intact.
Couldn't agree with you more. Is there a more formalized way for healthcare institutions to partner better with K through 12 schools? There are many OTPT, SLP nurses psychs already there with online systems who are routinely used. Seems like this partnership could be better synchronized.
That's a great question, really helpful for the kids and adolescents. Yeah, there are many partnerships between the county and community and academic systems where they're using video evaluations with parental approval in the school setting. And it's a way to provide access to evaluation. And sometimes there's treatment, or the treatment is done side by side in a slightly different venue. But this is really important because some kids and families can't get to traditional healthcare clinics. And sometimes the assessments that happen in the school, for example, are much more meaningful. There are some privacy issues, of course, with other kids are involved, but having assessments in school where the behaviors that are challenging are happening can be more meaningful to make decisions. So it does come back to what is an assessment versus can you have an ongoing treatment model? Can you do that with a mental health professional or a nurse on site with supervised care by video, which many people are doing? So you have to be flexible with the model. And for those of you who are investigating this, who are administrators, you have to see if you can bill, document, and reimburse appropriately.
Dr. Hilty, this has been fantastic. I'm sorry to say we're going to have to stop here. I think I, for one, could keep going. This is so fascinating to hear you think upon and pull on your vast amount of experience. So thank you so much for coming today. I really, really appreciate it. Like I said, we wanted to finish big, and you carried the freight for us. So thank you so much.
Thank you for having me, and thanks to all of you for attending. Thank you, Dr. Felker.